So now it's time to go far, far away from Europe in India. And I'm very grateful to Professor Anil D'Cruz, the President of the Union for International Cancer Control, for joining us this evening, night almost in India. He is just out from the operation. He's in the hospital still. So please, Professor Cruz, the floor is yours.
Thank you, Cornell. Just give me a second till I share my screen. I have a few slides that I would use. Here goes. So good evening to everybody from Mumbai, India. I know I'm out of the EU, but I share the same passion as with all of you all of ending the tobacco epidemic and making an impact in beating cancer. I am a head and neck surgeon. I work out in India. Head and neck are the commonest cancers that we see. That's 1/3 of all cancers, primarily due to tobacco, and close to 50% of our cancers are tobacco related. But I'm here today to represent the Union International for Cancer Control as the president. We have a large presence in Europe. Many of our members are from Europe, and a lot of our efforts, though global, are focused within the European region and the EU. I thought I'll start with a few slides on what is the UICC. It's the oldest and larger cancer control organization globally, and it was established in 1933. We are headquartered in Geneva, and we have a team of about 45 staff who are based in Geneva. But our activities span 172 countries. We have over 1,200 members. Now, our members are member organizations and not individuals. So we've got presence across the globe, and it's a mixed bag of members. We have academic institutions, NGOs, various organizations. We have an official relationship with UN agencies, the WHO, IARC, and IAEA. We have consultative status with the economic ECOSOC. We have more than 50 partners, including various cancer organizations, corporations, and foundations. And we've been founding members of 4 very large organizations that have subsequently branched off and do a lot of work in cancer control. The NCD Alliance, the MCCABE Center for Law and Cancer, the Cancer City Challenge Foundation, and the ICCP, which is the International Cancer Control Portal. Our mission is to unite the cancer community, to reduce the global cancer burden, promote greater equity, and integrate cancer control into the World Health and Development Agenda. And I think it's very similar to most of the organizations represented today, including the ENSP, which focuses predominantly on tobacco control. Our work is divided into 3 large buckets. The first is convening, and we provide some very, very vibrant platforms for the entire cancer community to join forces and drive change on a global scale. And 3 of our flagship convening events are the World Cancer Day that we just finished on 4th February with the theme, I Can and I Will, the World Cancer Leaders Summit, and the World Cancer Congress, both of which are held every 2 years with a large number of participants. Say the World Cancer Congress would have close to 4,000, 3,000 to 4,000 participants. And the Leaders Summit, which is by invitation, goes across the globe to different continents, and the regional leaders with a topical theme all brought together under one roof, and we discuss and give direction to cancer control globally, but more importantly in that region. The second large bucket of our activities is capacity building, creating innovative tools and skills to help our organizations, our members do a better job tomorrow than they already do today. These capacity building activities are focused a lot on local needs. We have leadership development programs where we target CEOs of major organizations, young leaders. We put together capacity building for peer-to-peer interaction at both the global and the regional level. We produce online education and resource material, various toolkits, webinars, training, and despite the pandemic, we've been very, very successful, both our partnership, advocacy, and our membership committee of holding all our members and beyond with these education and resource tools that we put. And then we've got grants for fellowships where they can go across for technology transfer, project improvement, workshops, or anything that is contributing to innovation. So that's the second bucket on capacity building. And third is our advocacy, where we integrate cancer control in the global health and developmental agenda, working across the policy cycle to help bring together evidence-based activities for cancer control. We engage countries, we engage with the WHO, civil societies, our members, and various other agencies in our advocacy activities. And tobacco is something that is high up there on the agenda for advocacy. Now, what is the UICC's work in tobacco control? We've largely divided our efforts into four. That's connect, engage, raise awareness, and evidence-based advocacy. So what do we do in the connect people? We connect our partners and our networks, connecting the cancer community with the tobacco control community so that we can synergize efforts in our fight towards tobacco control. We build and we strengthen networks with health organizations and advocates, as well as with other UN agencies. So we connect our partners and our network. We give expertise, we connect experts to share resources, link to key holders, various organizations, government individuals, and develop capacity building in the efforts towards cancer control. And complementary, the UICC's goal and role is to bring new complementary knowledge on networks and partnerships. UICC makes efforts to facilitate and coordinate all these activities together. Evidence-based advocacy, what do we do in this? So apart from connection, what is our role in evidence-based advocacy? Reliability. There's knowledge sources have been clearly identified and gathered by a group of experts. They're peer-reviewed and based on scientific methods. So we give our evidence-based advocacy some sort of reliability. It's absolutely unbiased. The information is objective in order to develop an impartial and neutral knowledge. And its independence. The evidence and advocacy messaging has been developed and shared in an absolutely independent and transparent manner, free from any groups of interest and external influence. I'm just going to add one slide on one of the organizations that the UICC created, which is the MCCABE Center for Law and Cancer. It's a joint initiative of the Cancer Control Council Victoria, the UICC, and the Cancer Council Australia. And basically what the MCCABE Center for Law and Cancer does, through world-leading research and training program, it empowers individuals, organizations, and government to use law as an effective tool to prevent cancer and other NCTs. So this is a resource that's freely available to anybody across the globe who needs law to tackle tobacco control within their region. We raise awareness, and I think this is something that's so important in tobacco control. Uh, Websites, press and social media, peer-reviewed journals, the World Cancer Congress, the World Cancer Leaders Summit, the World Cancer Day, everything has a stamp of tobacco control. We involve our members and partners in relaying our messages. I said we have over 1,200 organizations and 17 partner organizations, a strong base to take our message on tobacco control. And policymakers, we spread the FCTC and WHO resolutions together with tobacco control messaging. We relay resources from networks, engage local stakeholders and advocates to reach policymakers, liaise with country missions in Geneva, and to involve member states at the global level. So we raise awareness through various activities at the UICC. Uh, the engagement and priorities in tobacco control, uh, we support the FCTC measures uh, through various activities. The tobacco control measures, we strongly advocate raising taxes, and I think that came out elegantly in the WHO presentation about 10% decreases consumption by 3 to 5%, depends on which part of the world we are. We advocate smoke-free places, ban marketing to minors and young. Uh, we kind of negate the tobacco industry interference, counter misinformation of the public, impede to lobby government and decision makers, and report any dubious actions that we might note from the industry or from sources that counter the efforts of people. And we also now are focusing on novel and emerging tobacco products, and e-cigarettes is a case in point. In my part of the country, it's the smokeless tobacco, various heated tobaccos. In the Arab world, it's the hookahs and things like that. And bring evidence of these products and try to report marketing, targeting where these marketing strategies are aimed at targeting youth. And as we all know, if you don't start when you're young, there's a 90% chance that you'll never take to this harmful effect of tobacco. I'm going to end with a few slides of an example and from a country, our country, that's India, to just give you all a flavor of what happens at our country. If you focus to the first panel on the left, you can see that about 42.4% of our countrymen are habituated to tobacco. And your tobacco consumption is divided among smokers and smokeless tobacco. For us, smokeless tobacco is a very big problem. And this is a problem not so much in Europe, in the EU, and in parts of the developed world, but in many parts of our region in Southeast Asia, smokeless tobacco it is quite a problem and significantly bigger than the smoked tobacco. As in the EU, and again, these figures came, we have young people who use tobacco in the age group of 13 to 15. You can see that nearly 19%. There's a large number of young boys who use the tobacco. And again, a large part of this tobacco consumption is in the form of the smokeless tobacco consumption. and exposure to secondhand smoke, both among youth and among adults, if you can see, is fairly high. I draw your attention to a recent publication from JAMA. I think it was 2 weeks back, looking at cancer registry data. And I was alarmed to see, while the majority, 90% of cancers are tobacco induced, about 12% are smokeless, but more importantly, a large part of the 90, nearly half of them, are among past users. So people who've stopped. And again, I draw attention to both the previous presentations that very little is done on quitting tobacco. We do have other activities, and that's something that we must focus. As I say, even today is very late to quit tobacco, and probably I urge, that's the message, that we must also focus on getting people to quit tobacco. And here are again figures from our country showing the problems with tobacco quitting. You can see the quit attempt currently among smokers is 38.5%, smokeless is 33%. Healthcare workers do advise smokers. Nearly half of them are advised, and smokeless, about a third of them are advised to quit smokers. But it's very, the success rate, as we know, is low. 16% of smokers, but the percentage of people who quit smokeless tobacco is still much lower. And that translates into a large number of head and neck cancers. Oral cancer is one of the biggest cancers. And when you see Globocan data, you don't see oral cancers in the top cancers. But if you see the cancer registry data from our country, you'll see that the majority of, in the top 5, you'll have oral cancers in both men and women. And that's predominantly because of the chewed tobacco. What do we do for cancer control and tobacco prevention? And I think if you focused on the left panel, I think the first essential step is to understand the determinants of tobacco consumption. That's very important. We'll have to look at low prices, gaps in the tobacco law, lack of political will, low or no taxes, the pressure from the tobacco industry. We'll have to look at the public surrogate ads that go out and help or don't negate people starting tobacco. Socio-cultural factors, and in our part of the country, chewed tobacco is just accepted socially, and a weak or no base on the sale to minors. We'll then have to engage the main stakeholders, that's government, cancer, tobacco control community, groups such as this who are present today, civil society, and even citizens play a very important role. We'll have to implement cost-effective and efficient measures. And I think this point will come out in all presentations. It's come out in the previous two about raising taxes, probably the single most effective method to decrease tobacco consumption. We'll have to make smoke-free areas, and we'll have to ban marketing to minors, work on the advertisements, plain packaging, and pictorial warnings, and various others. And that in itself will decrease cancer deaths and tobacco-associated diseases. And then if you look to the panel on the right, such preventive measures will increase people's health and wealth and relieve the burden on the health systems, and it will increase national and health and economic benefits. I end thanking you all once again for this platform to share the UICC work, a few of my own thoughts on tobacco control. I congratulate you all on your efforts. I thank Yannick and the rest of the advocacy group for helping me to put this presentation together. And I end with the message to people who are not so aware of the UICC or are aware and are not members. We'd love you to join us and help us in our fight on cancer control and other NCDs as well. So thank you, Cornell, once again for the opportunity, the organizers, and over back to you, Cornell.